Despite advances in medicine and public health, glaring inequalities in access to healthcare and health outcomes exist in the Philippines. A major contributor is the mismanagement of human resources for health, including doctors. In previous studies, it revealed that 60% of Filipinos die without seeing a doctor, and the Philippines has a shortage of trained doctors and are distributed unevenly. Poor medical education partly causes the mismatch between competencies of health professionals and the health needs of the population. Reforms at the different levels of physician trainings must be considered, which include medical school, health system, and broader societal determinants. Some recommendations coming from medical students, which was done in a study in 2016, suggested to include prolonged exposure to the community, inclusion of more social science, public health, and leadership and management subjects in the curriculum, which I tend to agree. So there should be a scale up of medical education, but this will need the involvement of the Filipino government, the Department of Health, medical schools, and even medical students. The Philippines should commit to transforming medical education, which is an important step towards production of new health leaders for national and global health equity. Some specific strategies may include having an open communication channels among administrators, educators, and students, creating opportunities for meaningful interactions with peers and educators, investing in technical support in the medical schools and medical curriculum. And there should be more, for specific strategies, a more frequent formative tests over a single high-stakes examination may be preferred. There should be provision for a proactive psychosocial support for the students, and we should develop mental wellness program with a focus on teaching positive coping mechanisms to deal with stressors. For some strategies which may be specific for health crises and pandemics and calamities, just as what we have at the moment, there should be discounts on tuition and offer scholarships to cushion the pandemic's economic impact and advocate for greater subsidies from the government. We should develop bridging programs and prepare for gradual return to clinical activities and consider putting up simulation laboratories and other infrastructure that will allow face-to-face learning with social distancing. Suggestions are aligning health financing and primary healthcare goals with a focus on introducing a primary healthcare-oriented benefits package, provider payment mechanisms that incentivize preventive and promotive care, and the automatic enrollment for patients in the primary care programs, which is beginning or starting to happen already. Engaging the private sectors in the provision of primary care, and most health systems should need to engage both the public and private sectors to provide quality primary healthcare services. The stewards of government health schemes should have the essential information to engage effectively with private providers. Public and private sectors can work in tandem to deliver care. There should be better integration of the private sector into service delivery across the country's diverse geographic regions, and consider third-party medical auditors to improve the quality of care and system efficiency. I would like to have my disclosure because I have been involved in assisting the IATF even at the early stage of planning and preparation. In June 2020, being the chair of the sub-task unit for clinical management. So if you look at the organizational structure of the interagency task force, the IATF has an oversight over the National Task Force COVID-19 and has several response groups or the task group on response, and where the sub-task group on health belongs is the TGRO or the response on operations. And this sub-task group on health has 3 sub-task units, and one of which is the sub-task unit for clinical management. This is where I was involved for a time from June till first quarter of this year. We're there to ensure implementation of standards of care, infection prevention, and control measures. And we work with a technical working group core team for the clinical management and development of compendium for the clinical management of COVID. So I have been an insider. I have seen how intensive the planning and preparation was, but the weak link is in the third layer of the organizational structure, which involves the tactical part, the actual implementation and execution at the ground level, the provincial LGUs, the city, the municipal and barangay level. Considering that they are the first line of defense, they should have been capacitated, empowered, and supported fully. The coordination of the national and the local government should have been stronger and aligned and standardized. While this is understandable, the political differences should be set aside and let the LGU comply with the standard set by the National Task Force on COVID. The varying ordinances set by local chief executives make strict implementation of policies and standards challenging. Early negotiations for the procurement of the vaccine should have been done, even while planning and operationalization of the national vaccine program was still happening in the last quarter of 2020, such that we should have been one of the first countries who should have had allocations and reservations from the early developers of the vaccines. Recommendations of the health experts should have been the priority at the onset. We should consider and benchmark with the best practices of countries who have kept the incidence and death rates of COVID at the lowest. One of the best practices is that of Israel. Israel's leaders are all well educated and many of them have advanced degrees in science and medicine. They realized that at the onset of the pandemic last year, the only way to beat the virus was through herd immunity, and that vaccination was key to expediting this process. As soon as the big company announced successful phase 3 trials, Israel made a deal with this company to pick up their first 8 million doses for twice the price, which is $30 per dose, of what this company was eventually aiming to sell the vaccine. Israel also agreed to provide this company with the data on the efficacy of the vaccine on its population, and by November 2020, Israel had already acquired the vaccines it required to immunize its people. The Israel Prime Minister was asked 2 weeks ago why they agreed to pay $15 per dose extra, and his response was classic second-order thinking. He said that just in pure economic numbers, the total amount they overpaid was a minuscule fraction of what it cost to lock down the country. This is not counting the extra medical cost of COVID and the incalculable price of losing a loved one. The economic loss from just 3 days of lockdown was more than the overpayment for all the vaccines they bought. This is how smart people would think. We should not have let our guards down when the first surge was easing up. The plans for additional health facilities and additional hospital infrastructures for severe and critical patients should have been continuously addressed as planned in the third quarter of last year, such that when this second surge came, the tertiary hospitals should not have been exhausted and overwhelmed.